techniques or technique for performing radio frequency neurotomies at the cervical facet joint level. I have nothing to disclose. However, I have to disclose that I am a member of CIS, and I've learned when one of its members, Dr. Ray Baker, how to do these injections. And he has been instrumental in developing with other CIS members practice guidelines for spinal diagnostic and treatment procedures. And they have two versions of these guidelines, one published in 2003. And it was interesting because Dr. Baker provided for me the guidelines before they were even published. And he told me not to spread them out. And the first thing they did was to spread to all the fellows that they were working with me, and including Glenn. And after he told me, hey, don't divulge them anymore, I didn't divulge them anymore from that moment on. Anyway, they came with a second edition in 2013, and in order to get that book, I became a member. And it's pretty expensive to be a member of this society, but it's extremely worth it. So my talk will be based on the technique that I have learned by working with Dr. Baker and Dr. Dreyfus, and what they state should be the technique to be used and performed when doing this procedure on their textbook. So quickly review of the anatomy. You all know, I believe, that the cervical facet joints are innervated by the medial branch of the cervical spinal nerve dorsal rami, and the medial branch tend to curve around the anterolateral, lateral, and posterolateral aspect of the articular pillar that is marked with the arrows in those cartoons. For appropriate and best possible placement of the needle, most of the textbook or the textbook here, the CIS guidelines, recommend to place the needle or introduce the needle as close as possible parallel to the plane of the joint whose medial branch you want to block, like it is, like you can observe in figure C of this cartoon. You can utilize two different type of trajectory: an oblique path, or a sagittal or parasagittal path. And you can see on the cartoon below how using either the oblique path or the sagittal path, you end up reaching the medial branch over the lateral surface of the articular pillar of the vertebra. If you use the oblique path, you will reach the lateral surface of the articular pillar at a degree of at a 30-degree angle compared to the parasagittal path. These are cartoons that shows you how the needle eventually will be placed based on the type of path that you are going to utilize, that you decide to utilize. If you choose to start, if you choose an oblique path, starting with an oblique view, usually 30-degree angle compared to midline, or if you use a sagittal path, you see the way that the needle should look like, the needle placement should look like on lateral view and AP view, depending on the path that you've decided to utilize. The general idea is that the end game is to end with the tip of the needle in the waist of the articular pillar. The waist of the articular pillar of the cervical vertebra whose medial branch nerve you want to block. In this radiographic image from this paper published in Anesthesiology in 2014, you can see that in order to have the optimal needle placement for performing this procedure, you should place the tip of the needle into the dash parallelogram for either one of the medial branch nerve block and neurotomy at the C3 to C6 level, while the optimal needle placement, tip of the needle placement for a medial branch nerve block and RFA procedure at the C7 medial branch nerve level, you should place the tip of the needle into the dashed triangle. This image shows you on the left the lateral view for the tip of the needle that is placed onto the anterolateral aspect of the C5 medial branch nerve. For the C5 medial branch nerve on the anterolateral aspect of the C5 articular pillar, you can see on the lateral view how the tip of the needle is located posterior to the foramen at that particular level. The arrow indicates a second lesion that you can perform at that particular level. And the same location is observed on image B, which is an AP view where you see the tip of the needle at the C5 articular pillar lying on the waist of that articular pillar, and you can see the little circle that shows the location for a second burning of that particular nerve at that particular level. This was needle that was placed through an oblique pass using an oblique starting view. This is needle placement using a sagittal pass starting with a lateral view. You see on a lateral view the tip of the needle that is located again on the anterolateral aspect of the that articular pillar at C5, and how the tip of the needle is dorsal to the foramen at that particular level. The arrow on the left indicates a location for a second lesion at that particular level, and the circle on the right side, you see the electrode that is positioned in the waist of the articular pillar at C5, and the arrow that is immediately, and the circle immediately above where you're going to place the needle eventually for a second lesion at that particular level. For the C7 medial branch nerve, here you see on this cartoon sketches of consecutive electrode placement for a needle placement at that particular level for an RFA at that particular level. The cartoon A is a lateral view, and if you remember this picture, you can see that the tip of the needle is supposed to lie into that dashed triangle, which is which is just the lateral surface of the superior articular pillar. And you can see a lateral view on cartoon A and an AP view on cartoon B. And electrodes may lie on the lateral surface of the superior articular pillar and immediately above the top of the transverse process. Here you can see what you see in the cartoon in an image for the electrode that is positioned for a C7 medial branch radiofrequency ablation. You can see on the left image an AP view. The electrode has been placed in that position via a sagittal pass, and you can see that there is a circle that identifies the location for the second lesion at that particular level, and on the lateral view, you see the needle that lies on the lateral aspect of the superior articular process dorsal to the foramen at that particular level, and the arrows indicate areas where you can perform other lesion at that particular level. If you see that image on the right side and you remember this image, you see exactly where the tip of the needle has to lie for the correct placement of the C7 medial branch nerve block and ablation. let's keep this for a moment. For the third occipital nerve, the idea is basically exactly the same. You can use a oblique path, or you can use a sagittal path. And here you have images that identify the position of the three different positions of the third occipital nerve along the C2-3 facet joint line. You can see for this particular needle placement in oblique trajectory has been used, and you can see images A, B, and C that are lateral views for electrodes that have been placed along the location of the third occipital nerve in high position, mid position, and low position. And you can see the corresponding image on an AP view in high position, mid position, and low position. My suggestion to you when you're going to do RFA of the third occipital nerve, don't just be happy with one burning lesion. Burn as many times as possible, and burn at all different locations of the third occipital nerve. I'll tell you in a moment also why you want to do that, not just for the third occipital nerve, but for any other burning lesion, RFA lesion that you're going to perform at any level. This is instead is the location of the electrode that have been placed through a parasagittal trajectory. Remember, an oblique path, you start AP and then you perform a 30-degree ipsilateral oblique view. You have a 30-degree ipsilateral oblique view. For a parasagittal view, you start on a lateral view. You see the needle in high position in image A, in mid position in image B, and in low position in image C, and the corresponding images with the tip of the electrode in the high position at the articular waist of the C3 vertebral articular pillar, high position in image D, mid and low position in the image E and F. Over the course of the past few years, there has been an increasing interest into attempting to perform this procedure, this injection, with the use of ultrasound machines. And the argument that has been used is that you want to minimize the exposure of patients to X-rays, to radiation. Here you can see the location for the needle placement under ultrasound guidance into the groove that is identified between the two consecutive facet joints, and the location for the needle placement is indicated by the arrows. These authors, which are the same authors that identified the target for the ideal placement of needle for RFAs at the C3, 6, and C7 level, conclude that ultrasound can be an accurate technique for performing cervical medial branch nerve blocks, at least in volunteers, except for medial branch blocks performed at the C7 level. There were editorials to that article that were, and also they also concluded that one of the possible reasons why it may not be that easy to perform procedure at those levels with ultrasound, and why there might be a relatively low success rate for needle placement and optimal outcome, has to do with the fact that you may have problems in scanning with the ultrasound probe the distal cervical vertebrae, because the clavicle renders the placement of the ultrasound transducent rather problematic. Also, the target is located deeper under the skin than other possible targets may be, and that may, to some degree, decrease the visibility of your target altogether. a similar technique had been published via ultrasound guidance in another article that had been that had come out a couple of years earlier, and they basically had reached 2 years prior to the group that published this article in 2014 the conclusion that the ultrasound could offer a reliable alternative to fluoroscopy, at least for the placement of the needle for third occipital nerve injections and for RFA performed at C3 to C6 medial branch level. However, they were recommending for further studies to validate the efficacy of that technique. In an editorial that was accompanying the article published in Anesthesiology in 2014, Dr. Bhuvanendran and Rathmel were kind of refuting or refuting to some degree the conclusion that the article had, the authors of the article had reached by stating that more often than not, cervical facet arthropathy more often than not are accompanied by the presence of large bony osteophytes that make usual anatomy not very clear. And also they decided that it was not necessarily an entirely safe procedure to consider, because one of the possible complications that you may have with this procedure is inadvertent penetration of the needle into a small vessel, and they were not 100% sure if the sensitivity of an ultrasound machine was high enough to detect the possible penetration of the needle into one of those small vessels. So the possibility of intravascular uptake and or the lack of the identification of the possible penetration of the needle into a vessel was for them a problem. Last but not least, they also reported that all the studies that are published concerning the use of ultrasound-guided interventions in chronic pain are, for the most part, carried out by experienced sonographers, period, who have a lot of experience with ultrasound technique. And it is not that clear how rapidly neophytes can gain proficiency in performing these procedures with the help of an ultrasound machine, and when you compare that technique with the use of fluoroscopy. So I'm not trying to discard anybody's conclusion here. I tend to agree with Dr. Bhuvanendran and Rathmel, suggesting that it will eventually come, but it will require a lot of work and a lot of and some time. A few information about the physics of RFA. As you well know, there are traditional high intensity, high heat monopolar radiofrequency ablation procedure. Usually the volume of the tissue that is coagulated by a RFA procedure has an elliptical shape in the longitudinal section and a circular shape in the transverse section. For monopolar RFA, the recommended temperature is between 80 and 90 degrees Celsius, with lesions that are performed between 90 seconds and 120 seconds. After 90 seconds, the further growth of, or the further expansion of the lesion is somewhat limited because the coagulation tissue presents a higher impedance and resistance, therefore, to the flow of the current. More recently, cool RFA technique have been become available, and cool RFA procedure relies specifically on keeping the impedance of the tissue around the electrode low by cooling it. And by keeping the impedance of the tissues around the area where the electrode is placed, makes possible for the alternating current to hit the tissue longer, therefore producing a larger volume of tissue that ends up being coagulated. Usually the temperature utilized for cool RFA procedure is between 45 and 50 degrees Celsius and can be sustained for several minutes, more than the 90 to 120 seconds that you can sustain a coagulation lesion for a monopolar RFA. Usually cooling is achieved by passing some water through a channel which is incorporated into the electrode. And what several studies have shown is that cool RF electrodes end up producing lesions that extend more distantly than the lesions that you can create and that you can generate with a regular monopolar electrode. What does usually RFA do? RFA ends up coagulating proteins in situ and does not breach, does not literally transect the nerve. Usually you recover from a radiofrequency ablation procedure because some endocellular mechanism take place that allow the coagulating proteins tissue to regenerate within the axons. So as long as those proteins are coagulated, pain relief persists. Once the nerve is repaired, conduction also is repaired, is resumed, and pain comes back. Therefore, you have to try to maximize your efforts in order to increase the length of the nerve that you are planning to coagulate. And that's the reason why I'm telling you that you cannot be happy with one lesion. You have to perform as many lesions as possible. I have learned that the best outcome and the longer outcome in RFA procedure is directly related to the number of lesions that you are performing. And I have had patients that who have had successful outcomes for 2-3 years with RFA when I performed 3, 4, 5 lesions at those levels. And that's the reason why the higher the longer your or the more volume of tissue you are able to coagulate, the better. What are the possible hazards and complications that you can incur with these procedures? You can injure the spinal cord if you are placing the electrode too medial to the joints or inside the vertebral canal. You can injure the spinal nerve, and you can injure the vertebral artery, again, if the electrode is placed too far ventrally and anterior to the target zones for the cervical medial branch. Have you noticed that in all those pictures that I've shown to you, the tip of the needle is always dorsal to the, into the dorsal aspect of the foramen at the level where the procedure is going to be performed. With third occipital neurotomies, you can have a problem with ataxia. Therefore, if you have to do a bilateral third occipital neurotomy, just do one neurotomy at a time and see how the patient is responding to the first procedure and then go to the second. That is not necessarily, denervation of the cervical musculature can potentially be an hazard. So you want to try to limit the number of nerves that you can coagulate and you can denervate at the same time to avoid any possible problem with that. Actually, denervation of the cervical musculature is an indication that your procedure has been technically well performed. If you have doubts about whether or not your procedure has been well performed, you can ask your PMR or neurology colleagues to perform an EMG at the level where you have performed the procedure. And if you have a denervation of the multifidus muscle, at those levels you have done a good job. Whether or not that is going to provide pain relief or not, that's another story. That goes to all that you have heard this morning from Dr. Naidu and Dr. Poré, you need to select and you need to choose your patient well. And how do you choose your patient well? You choose your patient by doing cervical medial branch blocks. And you have to do at least two of those blocks with two different type of local anesthetics. There are a plethora of studies that shows that the best results in terms of complete pain relief with restoration of activities of daily living has always followed the control medial branch nerve blocks that were successful both times and was the essential indication for treatment with radiofrequency ablation. Actually, interestingly enough, one of the founding fathers of CIS, Dr. Bogdat, reports in his papers that in Australia, where he practices, they do 3 medial branch nerve block. Patients is blinded. Patients doesn't know what he's getting. Providers don't know what they're getting, and they get 1 block with 1 local, 1 block with another local, 1 sham block, and then at the end, and they do this block 1 week apart. And at the end of the 3 blocks, they unfold the blinding, see what the response were, and they decide whether or not at that point they want to do an RFA or not. And for them, the only indications for an RFA is when you have 100% pain relief, something that here in America is basically almost non-existent, as you all well know. Thank you.